I'd like to introduce Dr. James Lan and his patient partner, Teresa Atkinson. Dr. Lan is an assistant professor jointly appointed to the UBC Department of Pathology and Laboratory Medicine and the Department of Medicine Division of Nephrology. He is the medical director of the HLA Laboratories in Vancouver and a transplant nephrologist at the Vancouver General Hospital. A major focus of his current research, funded by the Kidney Foundation of Canada, aims to innovate new solutions for highly sensitized patients on the kidney waiting list. Teresa Atkinson, a dear friend of mine, has lived with kidney disease for 35 years and has spent more time on dialysis than living with a successful transplant. After a 17-year wait on dialysis, she was lucky enough to receive her third miracle transplant from the highly sensitized list. As a person with a lifetime of lived experience with a chronic disease, Teresa is a passionate advocate for empowering others and building community. She has 25 years of volunteer experience with various kidney-related health charities, raising public awareness, peer engagement, promoting organ donation, strategic planning, and governance. James and Teresa, thank you for joining us today.
Thank you very much, Mary. And I'd like to thank the organizers for having us here today to present our work. To follow Dr. Fingra's very excellent lecture, our research has been targeted towards finding solutions for difficult to match patients by looking at how to cross antibodies. And we couldn't have done this without patient engagement and also the community being involved at the same time. So we'll proceed by talking about the research first, and then Teresa will speak to the patient engagement process. Next slide, please. So in the kidney transplant world, much like other solid organ transplant, we have many patients who are very difficult to find a match. These are patients that we call highly sensitized. And these are essentially patients either through blood transfusion or pregnancy or previous transplant, they have made a lot of antibodies. When they make these antibodies, they have a higher risk of rejection. And so they have to take a long time to find a match. And what I'm showing in the graph on the left side are patients measured by a metric in our community called CDTRP, which is a measure of how broadly sensitized they are, how many of these antibodies that they have. So to give you an example, if someone's CPR is 95%, it means that they only have a 5% chance to match someone in the population. You can imagine when they go up to 99%, now they only have one single person that can match them if the donor pool is 100. So as CPR goes up, most patients, they have to wait longer and longer before they can find a match. To help with this, the Canadian Blood Services introduced national organ sharing, so we can move organs across the country to find a match for these difficult to match recipients. So what you see here on the left-hand side is that this program has been very successful, that patients who are 95%, 96, and 97, they actually don't have to wait for very long before they find a match. But the difficulty lies for patients who are 99% or 100%. If you look at the 100%, which is the dark red line, for over 5 years, only about 40% of patients can actually find a match from this successful national program. But what it means is that the remainder, they cannot find a match, and many of them, they become too sick, waiting on dialysis, or many, they actually pass away. So what we hope to do is actually to innovate a new national program that we call the first of its kind, Willing to Cross program. And the idea here is that the entire program so far has been very paternalistic. Is that if patients have antibodies, we say, no, you're not allowed to find these donors. We want you to find a better match. But if we allow some of these patients to cross some antibodies that we deem to be low risk, that will open up the donor pool, and perhaps they don't have to wait for as long. So to do this, basically, we want patients to assess and tell us, would they find this program to be acceptable or not? Because this is the pro, as you see on the right-hand side, the green boxes, that this program may improve the chances of receiving the transplant, leading to reduced wait time. But what about the con side of this program? That perhaps there's a slightly increased risk of rejection, and perhaps these kidneys that could have been better used for compatible patients could have lasted longer than someone who's deliberately crossing antibodies. So these are the things that we wanted to evaluate patient perspective to tell us whether they find this idea to be acceptable or not. Next slide, please. To make things even more complicated in the transplant community, although people have crossed antibodies before, the way it's been done in the past has been quite heterogeneous. The data as it exists right now makes it very difficult to tell patients which antibodies are super high risk or very low risk. And therefore, it's hard to articulate to patients what is their actual risk if they cross antibodies. To work around this, we, with Canadian Blood Services, came out with an adaptive design program where we take patients 6 at a time, as you see on the very top, starting at what we deem to be the lowest risk tier of antibodies to cross. And if all of them do this safely, then we can incrementally go up the risk of antibodies until we find a point when we and the patients feel that it's unacceptable to proceed anymore. So this is a very novel idea that has been used in oncology for many years, but we feel that it might be appropriate to be utilized in the kidney transplant world to help patients open up access to transplant. Next slide, please. So that is the idea of the research program. And really, equity, inclusion, and diversity are fundamental to this program because, as I said earlier, we're sharing kidneys across the country. So if we're going to do a program like this, we need to make sure everybody across the country, patients, providers, are find this program to be acceptable. And it's important that we listen to them and get their feedback before we go ahead and execute something like this. Next slide, please. The challenges when we're conceiving this research program is, well, how do we effectively communicate these very complex scientific ideas to patients? Even when I explain to my transplant colleagues, they have to listen to this several times before they fully grasp what is it that's being proposed and the nuances of these programs. These are very complex science ideas that really take a while to explain to people appropriately. How do we ensure patients from diverse backgrounds are included? The highly sensitized patients, they really make up people from all diversity of backgrounds. We have many pediatric patients, they have failed their first transplant or second transplant and have become highly sensitized in the process. So that's one age group. Conversely, we have patients who are much older. They have had multiple pregnancies or transfusions, and now they're highly sensitized. And as you can appreciate, pediatric patients, they might be able to withstand dialysis for longer before finding a match, but the 70-year-old patient might not have so much time to wait for a perfect match. So we have to take that into consideration. Gender is an important consideration as well. Many women have had pregnancies and they have developed antibodies. And so they make up a large proportion of candidates who are highly sensitized. It's important to understand their perspectives as well. Ethnic and cultural backgrounds are really important as well, because when we discuss risk, that has different meaning to people from different backgrounds. And again, how do we convey these very complex ideas to all different ethnic background patient groups effectively? That's a challenge as well. And geography, of course, people from different regions, they have different access to transplant provincially, and we have to take that into consideration. More importantly, how do we ensure the study materials that we develop for the research are understandable and appropriate for for the study patients? And how do we recruit patients from diverse communities? These are the challenges that we as scientific investigators have to face. Next slide, please. So to do this, I realized that with my partner, Dr. Marie-Chantal Fortin, we couldn't do this by ourselves. We really need patient partners who have lived experience and also understand what it's like to effectively engage patient groups to do this work. We're lucky enough to recruit 4 patient partners with Christy, Kai, Teresa, who will speak to you just in a minute, and Kauji to help us with this work. Next slide, please. We also understood that we didn't want this to be a scientific team-led research program. We want patient partners to be really a dominant force within our research. And to do this, we couldn't do it without actual funding support. I just want to acknowledge the Vancouver Coastal Health Institute because they provided actually funding to do patient engagement to support this research. And we were very lucky to be awarded their first grant. Next slide, please. So once we had the funding and the patient partners, we laid out a very careful plan timeline about how we're going to do this patient engagement work. You can see that in the first step, we have to find the appropriate patient partners. We're very lucky to have 4 of them who are highly engaged and understood the questions and were really quite interested and engaged with the research as well too. We had a workshop on introducing them to the research project, training on what kind of methodologies we might use. And then we had the patient partners consult with their own patient network communities for feedback. We really went through our research objectives and questions carefully with them to plan them out and tweak them as necessary. And as you'll see in Teresa's presentation, we really allow patient partners to take the lead on developing research materials because ultimately they were the things that would be used to engage the patients. So without further ado, I will end here and pass the presentation over to Teresa.
Good morning. Thank you, Dr. Lan. I'd like to acknowledge that I have the privilege to live, work, and play within the ancestral, traditional, and unceded territories of the Okanagan Syilx Nation in BC here. So I just wanted to point out some of the patient partner significant points of involvement that we thought were important as patient partners. So we started with the initial meeting, as Dr. Lan said, and then we reviewed concepts and training, and we had the privilege of having their access to the doctors and asking all of the questions. But as you can see, that took quite a long process for us to understand. And so it was suggested that we think outside the box and try and figure out a way that we could communicate this to the patients that were going to be interviewed, and then potentially in the next step of the study, possibly participate in the project. So it was decided to try and do a video talking patient to patient. So the patient partners took this on by themselves, or not by themselves, but with the support of Dr. Lan and the committee, to do the video planning and actually do the video on their own. So we did everything from creating a plan and a time outline and doing the filming, editing, refilming, transcriptions on our own, and coordinating the French translation. And then of course we did interview reviews for the actual interviews and actual testing with them. So one of the benefits that I found of being involved in this project was we actually had the privilege of doing the ethical research course. So that was something really enlightening for me to learn about the ethics of research and how it was so important. Next slide, please. So as you can see, we started with a video content outline, and what we wanted to cover was why research was important, why this research, what it was about, where the pilot test was going to happen, who was involved, and how we were going to do it. So because it took so long for us to figure that out, to figure out how we were going to do it, that adaptive design study, we thought we would assign each person one of these categories, and we would go and try and create slides and a video script, if you will, that would then get approved by the team. So we went ahead and presented this back, and it was approved. Next slide, please. So the next step was to agree on a timeline for the video production. And as you can see, that was a very short timeline that we had to get it done in. So after the presentation was agreed, we shared with the team for approval. We created slides, which everyone did this. It wasn't just me. It wasn't one person on the team. All of the patient partners were creating their own slides. We had special meetings with Dr. Lan to go over stuff that we were unclear of. And of course, it was being reviewed by the whole committee. Then we did videotaping tips just to make sure that we were all consistent, because I thought we would do this by Zoom originally, because not everyone has skills to do videotaping, but we were lucky that every one of the patient partners were able to do this on their own. So then we did the first draft of videotaping, and we had it compiled and we sent it to the team for review, and it came back with a few comments. And then we did retaping. And so after the retaping, we compiled it, and then it was edited and finalized, and we had to do the transcriptions, and then the French translation was added, and we had a final product. Now, we didn't quite meet our deadline. We were, I believe, a couple of weeks late, but it was still within the time frame that was needed for the interviews, because they didn't happen until later in the year. Next slide, please. So you can see some of the slides we created, and we did this to create some interest, visual interest in our presentation, much the same as previously was done, to get some attention, and also people learn different ways. Some of the more challenging concepts is what we struggled with to simplify them, specifically, things that cause the antibodies, and what is AMR rejection versus other types of rejection. And to get across the chance or the point that highly sensitized patients may or may not find a kidney in the current wait lists. Next slide, please. So of course, one of the most challenging, again, was the type of study we were going to do. And so what we ended up with after much discussion was to actually turn the dots into people so that it was more relevant, and to give some examples of what might happen, what decisions. This is not specifically what was decided, but that patients could understand how the study might work. So in the first tier, if one person had AMR rejection, then perhaps the study could continue. That might be a reasonable expectation. If two people had AMR rejection, maybe that should be repeated so that we were sure that that was the risk. And then if 3 people had AMR rejection, they may consider stopping the study altogether. That made more sense to us as patient partners to understand the concept of the study. Next slide, please.
Hi, Teresa.
So
go
ahead.
Friendly 5-minute reminder.
Okay. So this is a sample of the Willing to Cross video that they're going to play for you. It's just 2.5 minutes.
I'm Christy. I'm a heart transplant recipient and also one of the patient partners on this Willingness to Cross project. As a heart recipient, I know that antibodies and being highly sensitized is an issue that really does transcend all organ groups. It's not just limited to kidney patients. And I believe that this project can really help contribute to the larger body of knowledge around antibodies, around being highly sensitized, and that's going to ultimately benefit all transplant recipients and everyone waiting an organ transplant.
Hi, my name is Koji, and I'm a 2-time kidney transplant recipient and a patient partner on this project. Having had my first kidney transplant at the age of 4, I know that I will have a difficult time finding another kidney that matches when I eventually need another transplant due to my highly sensitized status. I was fortunate enough to be able to receive a second kidney transplant in 2018 from a family member, but I still remain highly sensitized. This study would hopefully allow for patients like me to receive a kidney without waiting years and years and years on the wait list, and in some cases dying before a kidney becomes available that is a match.
Hi, my name is Kayi. I'm a 2-time kidney recipient. I was very lucky to have 2 kidney transplants, but there are some highly sensitized patients who have been on dialysis for years but still haven't got a kidney. We know that being on dialysis is not easy, and it can be very stressful when the wait time is so long. Hopefully, the Willingness to Cross project will shorten their wait time.
Hi, I'm Teresa, a 3-time kidney transplant and a patient partner on this project. It is important to me. I was one of those patients waiting on the list, 100% sensitized with a 50-50 chance of ever finding a match. After 17 years, a very long wait, they found me a match. and I've been living with that kidney for the past 6 years. The Willing to Cross project could provide hope for all those complex patients waiting on the highly sensitized list.
Now here is where you come in. We want to hear from you in this interview what you think about this project. Specifically, we want to know your thoughts on two main questions. One, whether you think it's appropriate to transplant kidneys in patients who make an antibody to the kidney they're receiving, and two, what you think about the adaptive study design. We want to hear from patients as this study can impact them, and we want them to have a voice in shaping how it progresses. Patients can use their unique lived experience to provide a valuable perspective to the study and shape how it proceeds.
So that was just the introductions and personal impact statements with the French translations. We had thought that we might translate it in other cultural languages that for the at-risk groups, but because of the limited number of interviews, that wasn't feasible at this time. But we will revisit that at the second phase of the project, should it be required, so that patients can understand. Thank you. Back to you, James.
Thank you, Teresa, for the excellent presentation. So I just want to show some of the preliminary results that we have. And I think, as you can appreciate, through the contribution of the patient partners, when we deploy the research, we had overwhelming feedback from our patients. Within 2 days, we have reached the target recruitment of subjects that we wanted for the study, which is 20 patients in BC and 20 in Quebec as well. And my coordinator told me that we had never had this type of feedback in all of our studies in the past. We were looking for 20, as you can see, 39 participants replied within 2 days, and we had 34 consented, and now over half of them interviewed already, and similarly in Quebec as well. Next slide. And in terms of the patient characteristics, we wanted a broad range of diverse backgrounds, and as you can see, that is represented here. We had a very good representation from female patients from all the transplant centers, English versus French speaking. The age, there was a good spread between the lower group to the higher age group, and also the ethnicity breakdown as well too. Next slide. We wanted patients, because these are really difficult concepts to convey. Again, we wanted patients that are involved with different level of education in terms of their understanding, to make sure they truly understand the risk and the study design that we're discussing, and also to get their feedback as well too. And we have a number of patients who are either currently active or they're on hold on the wait list. Next slide. The wait time of these patients have been significant because we are looking at highly sensitized patients. If these kidneys are diverted for waiting to cross, that might have impact on patients who are not highly sensitized as well too. So we wanted to have patients who are just starting dialysis. They haven't waited for 7 or 10 years because their thinking might be actually swayed towards one side versus the other. So we were able to capture those patients who just started dialysis as well. And half of them are highly sensitized and the other half are not, which is what we wanted the patient breakdown to be. Next slide. So in conclusion, I hope that I've conveyed to you, we as the scientific investigators, we couldn't have done this without patient partners. Really, they brought like a whole new level to the patient engagement experience. They give us really new perspectives. They enhance the research objectives, fleshing it out a little bit more for us, the methodology and the materials that we use for patient recruitment. And so I really want to just highlight the great work that these patient partners have done and how they could be better utilized for future studies as well too. So with that, I just want to go to the conclusion slide to thank everybody, Marie Chantal and Fabian, that have really co-led the study in Quebec, our wonderful patient partners, coordinators, and the other transplant professionals and Canadian Blood Services that have been participants of this work. Thank you very much.
Thank you very much, James and Teresa. I really like the way that you incorporated patient engagement into the project. That really seems to be well entrenched in your research. Again, I just want to remind you that you have several ways to ask questions. You can either raise your hand or send a question to Manuel in the CDTRP Q&A, and then we can also check out the chat box. I do have one question in the chat. from Murray, and he asks, how did you get through the confidentiality issues to obtain your original large lists?
So we have ethics that we can send these invitations to participate research for patients on the dialysis wait list. And we have got the ethics approval in BC as well as in Quebec as well. And as one of the respondents said, when you do a cold email send out like that, it's actually very hard to get engagement because we don't have a way to really explain the nuance of the research to them. And that's why development of a very engaging video or these brochures are super important to get patients engaged at the first site.
Thank you. I also want to ask, besides the Willing to Cross program, what else can we do to address issues of equity in terms of access to transplant for difficult to match patients?
And thank you, Mary. That's an excellent question. I think the Willing to Cross has a lot of benefits for some of the patients, and it's not going to be for all patients. And I say that because not everybody can withstand the process of crossing antibodies. So for some of these patients, they might be okay, like the like the more robust patients. But for some of the more fragile patients that cannot withstand some of the issues, they really need to be thought of carefully in terms of risk assessment. For pediatric patients, I know there's a national program that's coming up as well to try to match these pediatric patients better so that their risk of becoming highly sensitized is much less in the future. And so where we need to develop progress is to get feedback from our patients on how can we explain things better to them. And we already have preliminary feedback that our physician description of risk is very vague. We need to do a much better job because without communicating to them what is risk, what is their risk actually, then they don't know actually what to do, which way to go with in terms of their strategy to receive a transplant or remain on dialysis. So for instance, one of our work right now has shown that the blood group of candidates actually has a major impact as well, in addition to their antibody profile on their access to transplant, and that is not being considered right now. So by merging the two together, we can more accurately tell patients, are you going to find a match likely within the next year? Or maybe you're someone who's going to wait for 10 years. That might inform which strategy they might want to go for.
Mm-hmm. Thank you. Thank you. Manuel, I can't see if you received any questions. I just wanted to check in with you. Did you get any questions in Q&A?
Not directly. I see one here from Marie. Sorry, I had to mute myself for a sec. How did you get through the confidentiality issues to obtain your list? Yeah, you got that one? Okay.
Yeah, I got that one. Thank you. Nope. Lori has a question though too. Are you considering ABO incompatible transplants?
Thank you, Lori. That is an excellent question to begin with. We are not going to be crossing ABO at the same time. Some of the previous data have shown that by crossing ABO incompatible transplant and HLA antibody at the same time, the risk of rejection, there's a synergistic effect. So to begin with, we would be doing ABO compatible transplants, but crossing just HLA antibodies to begin with. This is already an advancement from some of our other colleagues in other countries where they only restrict to ABO identical transplants, which in my opinion is much more restrictive to what we do in Canada. So we really want to just maximize things first, deal with the HLA antibodies, and then if the results are acceptable, then we can consider another aspect to the RMS to suggest ABO compatible transplants.
I was actually just getting at the question of whether if you could find an HLA identical donor, you would, by crossing the ABO barrier, that presents an opportunity for highly sensitized patients to get potentially the HLA match, which is probably even more important than the ABO match.
Absolutely, I completely agree with you. That's another strategy to say if they don't have HLA antibody against the donor, then perhaps by crossing ABO, that's acceptable. I think we have discussed that. And Sean, I think you put up your hand up. Maybe I'll let you speak to that from the national level.
Thanks, Laurie. That's a great question. As you may know, Anne is actually helping with an ABO incompatible strategy, but it is going to start with the kidney care donation program first, and then we'll look at it in the deceased donation context. I think my colleague Kathy Yesser's on the line, and so she'll be part of the responsibility for implementing that. But ABO incompatible, at least ABO incompatible like So non-A1 donors will be the first step, but just similar to the adaptive design that James was describing for willing to cross, ABO incompatible will also have kind of a stepwise progression, starting with some of the easiest ABO incompatible.
Thank you, Sean.
Thanks, Sean.
Thank you. Thank you, everybody.